That looks better. Good morning, everyone. So I'm going to be talking about transforaminal endoscopic lumbar discectomy. Dr. Koshland did a great demonstration yesterday, and so this should all be a review for everyone. So let's just jump into it. We'll kind of go over some surgical indications, technical pearls, kind of focus more so on the setup and the procedure itself, and then we'll go into a stepwise approach of how to do the procedure, and we'll go and talk about some pitfalls and how to avoid them. So when you're thinking about your surgical indications, of course, you have someone that presents to you with usually radiculopathy. You have to think about this from a very minimally invasive targeted approach. And the goal is not to just remove disc, but it's also to inspect the disc and evaluate the actual herniation and the neural elements and make sure that you've gotten complete decompression. So a central zone disc or a central disc protrusion or herniation with extrusion of that disc material is probably something that you shouldn't do as your first case. It could be quite challenging for a transforaminal approach as a new surgeon who's trying to, master the techniques. So I wouldn't start there, but it's definitely accessible. It's definitely doable. Subarticular zone herniations are a little less tricky than central zone. And then, of course, the foraminal zone, these are discectomies that are usually done a little bit more simpler. It's kind of mimics what you do here in the lab. You're not doing a lot of significant dissection of the neural elements, but you can actually see them and find the disc herniation, find the compression, and remove it. The common misconception is that extraforaminal disc are the easiest because the endoscope can get you right there and it's going to make things easy. I disagree. I think these are for expert level cases. You really want to be able to understand how to target the actual pathology and then get great visualization of the exiting nerve root, find the actual compression, and then remove that in a very structured fashion. And then, of course, this transforaminal endoscopic lumbar discectomy approach is very similar to just creating opening of the foramen, removing bone, doing a trans-SAP approach. So they go kind of hand in hand. So all that being said, let's go into some cases. So this first case is a patient that you can see has a central disc herniation. Surprisingly, she only presented with back pain. And for her, you can see that there's this caudal migration of that, cranial migration of that disc fragment. You can see her reported outcomes on the side, and at 1 month she's pain-free, substantial reduction of her back pain, and of course no leg pain, which is a surprise to me. But for us, the approach was transforaminal because she has a little bit of a grade 1 spondy. Not saying that we were afraid of that, but I didn't want to remove any bone if I didn't have to, and so a transforaminal approach was appropriate in this patient. This patient is a little bit more complicated. You can see the disc at 4-5 is completely decussated. There's no actual foraminal height. And I always struggle with whether or not this patient's going to need a fusion, but I know that doing a transforaminal discectomy in this patient first means I'm going to get direct decompression. And if they do well, as this patient did at 3 months, if they do well, I save that patient from having a fusion in the interim. If that patient develops further progression of their disease process and they need a fusion, that's always an option later. But doing a decompression first is always my goal. So you can see this is more of almost like a subarticular disc fragment. And you can see there's a little bit of the SAP kind of wedging that nerve between that disc fragment as well as the SAP. So a trans-SAP or even just doing a transforaminal approach, bring your scope out, initially very lateral to your foramen and working your way in is a great approach to directly decompress that nerve.
Sorry, John, did you do this trans-SAP or
I did this one transforaminal, yeah.
Transforaminal,
yeah.
Trans-SAP?
No, transforaminal, yeah. But if you wanted to do trans-SAP, you could. Wouldn't do it as your first case if you're, a novice surgeon, because you really need to know where that nerve is. And that's not for you, Hofstadter. Let's go back. So a few more cases to present. We're here. Excellent. So with this patient, a younger patient, you can see that at 3-4, there's this extruded disc with a little bit of caudal migration, and this patient's very young and active. Of course, you could do this interlaminar, remove some bone, but again, kind of sticking with the whole point of this case, doing a transforaminal approach in this patient was reasonable. The foramen were wide open, and it was it wasn't a struggle to get to the actual disc fragment and remove it. So this patient did well very early in their recovery and has been doing well since. And then this patient was really one that I wasn't sure was going to do well with a direct decompression. In this lateral MRI, you can't quite see this patient's SAP is actually jabbing into the nerve, causing significant severe foraminal stenosis. And then you can see they also have a little bit of a subarticular, possibly even a little bit of a far lateral disc herniation as well. And so, I counseled this patient quite, extensively about the risk of needing a fusion, and this person had a pretty significant scoliosis as well, and she did not want that. You can see the muscle in the back on this axial MRI that, she's not very active. The core strength is pretty poor, and so, of course, the concern for me is she's probably going to need a fusion. Well, at 3 months, she's pain-free. She's having increased quality of life, and she's working on her core strength. And I think that's the beauty of endoscopic spine surgery is you're not necessarily pursuing, initially a fusion and hoping that they do well. What we're seeing is these patients get back active quality of life from doing these procedures that, when applied correctly, you can have great outcomes. So let's show some more data, because we love data in this presentation and in this talk, and I think data really backs it up. So we're looking at, from our verified patient-reported outcomes app, Spine Healthy. These patients are essentially all the transforaminal cases that we've done enrolled since June 1st of 2023, or sorry, prior to June 1st, 2023, 138 patients from multiple different sites. You can see that in the first 2 weeks, their pain and their legs is improved on average by roughly 3 points. Same with back pain. And then when you take that out to 90 days follow-up or 3 months follow-up, the reported leg pain improvement is close to 4, and then the back pain a little bit lower, but still maybe 2.5 to maybe closer to 3 for some of these patients. When you look at their disability, these patients at the first 2 weeks, as expected, probably dealing with postoperative pain, but they're a little bit, a little smaller improvements in their disability. But at 3 months, that disability has improved by almost double compared to the immediate postoperative phase. So let's go over some technical pearls. I think the presentation that was done yesterday in the lab was amazing, and I think really to kind of figure out how we got there is quite important for the people starting out. So I am a big user of the Jackson frame, the Wilson frame on the Jackson table, open Jackson table, keeps the belly hanging, helps with decreasing venous flow or venous pressure, and helps decrease bleeding intraoperatively. But this also helps open up the foramen so that you can actually safely target the foramen or the inferior portion of the foramen and avoid actually causing any injury to the nerve. Of course, you're going to need an endoscopic tower. That's a no-brainer. But the water management, like Christoph alluded and like Dr. Brooks talked about, there's different techniques, but it's very important. You need to practice, for not just the lumbar cases, thoracic cases as well. And if you're not paying attention to your water management and using the lowest setting possible for that case, you're going to get into this habit of setting it the same place every time for every case. Then you're going to run into issues with water management. You're going to run into issues with complications and changes in SSEPs. I think it's also important to make sure you don't have cold irrigation. I think that can change your nerve monitoring as well. I would definitely say have a C-arm with C-armor. It's important. You're going to be taking a lot of x-rays, and you're going to be going AP lateral, so that's definitely a must. And then for transforaminal cases, nerve monitoring, right now we're saying that it's a must, but I think there's going to be some data coming out shortly to show that it's not always necessary, especially if you have navigation. And this is going to be the room setup. So you can see, in general, you're having the patient prone on a table, usually on the Wilson frame. You want the C-arm to come in opposite from you, so that way you can take AP and lateral x-rays and swing the C-arm out. The goal is to have the monitor directly in front of you as a surgeon. For transforaminal cases, I actually like to put the endoscopic tower and the monitor at the feet, because I like to stand facing the way in which I'm going to be operating. So if I'm looking at the inferior index level, the top of that pedicle, I'm going to be looking south or towards the feet, and then be able to keep a nice view of the monitor. But this is an example of one of my colleagues. He's doing a case, and what you're seeing here is that monitor is really at eye height, and it's ergonomically to his advantage. The C-arm's coming out, coming on to him, or sorry, coming in from the opposite side. So when it comes to targeting, I think enough cannot be said about how important targeting is. So if you want to have, a great case with great outcomes, it starts from one, preparing the room, and then two, you then prepare your patient and position the patient. And after you got done with that, the next step is the targeting. If you're not good at targeting, you're going to struggle through the rest of your case. So first and foremost, it's always important to get a true AP and a true lateral. And I can't emphasize that enough. Definitely would say neuromonitoring because, you want to make sure you avoid any injury to the nerve. Honestly, I think that, again, we're going to see a lot of information to show that it may not always be necessary in some cases. And then the targeting technique really is going to be whatever works best for you. So once you find a technique that you like and it's reproducible and gets you where you want, continue to build on that technique and use that technique. Don't go changing things. And then, of course, as you target, it's important to know the anatomy of the area. You can find that once you've gotten to a place that you think you are, you're actually not there, and then you're lost in spine. And if you don't know the anatomy, you're going to flail for 30 to 40 minutes before you realize, I'm nowhere near where I thought I needed to be. And then last but not least, it's always important to correct the surgical level or confirm the surgical level. So in this image here, what you're seeing is this is my PGY3 resident. She's got a nice, comfortable pistol grip. So for transforaminal, and even in all endoscopic spine surgery, the goal is to be comfortable with this case. You shouldn't be having a death grip on the scope. The scope should be light and free in your hands. And you can see this is a nice, comfortable pistol grip. If we zoom in, you can see she's got one index finger. For some people who have longer hands, or if the tube, depending on your grip, you may use your middle finger, or you can use your index finger, but you always want to keep some downward constant pressure on the actual outer tube to make sure that you're controlling where that tube is going. You don't want it to migrate, and you don't want to lose your position. And then it's important to work in planes. When it comes to doing endoscopic procedures, you should be starting from the outside in. So if you're doing your foraminotomy, don't go in and out. I mean, you're just going to drill a channel. You're not going to get anywhere. Start outside, work in a plane, stay in that plane, and then advance your tube. Go to the next plane, develop that plane, and advance the tube. This gives you an opportunity to see what's behind you, as well as know that there's nothing, see what's in front of you, and make sure you know there's nothing behind you as well that you could have injured on your way in. And then avoid being a statue. Let's go back. Let's avoid being a statue. So what I mean by that is, our general rule or general way of thinking when it comes to spine surgery, we sit there, we stand for hours on end, and we just operate like this, 2 fingers or 2 hands, and we're just looking down, and we don't move. By the end of the case, your feet are going numb. You haven't done anything. In endoscopic spine surgery, it's a very mobile surgery. You're going to be constantly changing angles, changing the approach. And the whole goal is that with this endoscope, with this amazing tool, you have 360 degrees of freedom. So you should use that to your advantage so that you can minimize the disruption of normal tissue, and then also get better visualization. Because once you can see things, you can see what's being compressed, and you can decompress it effectively. And then, of course, always visualize the tip of your instrument. If you're not, there's a good chance that you can cause a complication, a durotomy, a nerve injury. So Osama kind of showed this yesterday in the lab. You can see that he was working with his scope, and then he would turn the scope 90 degrees to his instrument. So that way you can see where the tip of your instrument is doing. So, of course, we've talked about targeting. I won't go into too much to it, but you're targeting the middle portion of Cayman's triangle. Depending on where your pathology is, your approach, how you target may change a little bit, but the concept is pretty much the same. You want to stay outside that mid-pedicular line, and you want to stay posterior to that vertebral body line, posterior vertebral body line. This is the way that I was taught. Essentially, you're making these, on the true AP, making these lines on the skin, kind of marking the inferior level. So if you're doing L4, L5 as indicated here in this image, you're marking the superior end plate of L5 on the AP, and then you're also making your trajectory from cranial to caudal in the AP direction. You can go to a lateral to confirm. You can see here, you can't see that. Well, at the top of the image in the center of the screen, you can see that at the very top of that image, there's a spinous process line, spinous process line. And that instrument, that blunt tip instrument, is right at the tip of the spinous process. And depending on how far lateral you need to go to actually get that tip, that instrument tip near the spinous process will determine your distance from midline. Generally, it's usually 8 to 10 in the upper lumbar spine, and then closer to 12. Hardly ever go past 12 unless it's a large patient in the lower lumbar spine. So this is an example of a case that we did. I think this was one of my residents doing a targeting. So you can see this is at L4, L5. You got a nice centerized, the actual level is center of the fluoroscopic machine. We're actually taking a shot through the end plate of L5. We've made our approach. This was a subarticular disc. So you can see our approach is really just to get to that subarticular portion of the foramen. And then we placed our needle under AP. There's a lateral to confirm that we're not actually in the disc just yet. And then you can see that we've confirmed that we're at the right level. And then we bring in our instruments, and then we bring in our scope. And of course, you always have to take this jury shot just to confirm if anyone had a question of if you were there or not and you did what you said you did. This kind of suggests that you did. So that being said, you've gotten your scope in. The first thing you're going to see is soft tissue in front of you. You want to remove that slowly with the pituitary. It's always a common habit for people who are just starting out to just grab and pull, but you really want to grab and look to see what's coming with it. If you see something behind you that's moving that shouldn't be moving because you see really just fat or maybe even a little bit of muscle, then you might want to let that go and develop the plane that's there. But eventually, your first step in the procedure, now that you brought in your scope, is to identify the superior surface of the inferior level pedicle. So in this case that we're talking about, this would be the superior surface of the L5 pedicle. Once you've done that, you can then use your pedicle to, let's go back. All right, well, I guess this video is not working. Once you do that, you can use your blunt dissector radiofrequency ablation probe to develop the plane between the disc and the dura. Essentially, this video was supposed to show oh, you can see it perfect. This video is showing that we can actually identify, there's a calcified disc here, but we can identify the plane between that calcified disc and the dura. And really, you want to know where that plane is because on the opposite side of that calcified disc will be neuroelements, and it kind of helps you understand what pathology is actually, or what the pathology is actually needs to be taken care of. Avoid you removing unnecessary disc. So always, one, developing planes, identifying your goal of surgery, and this step of the procedure is quite important. And then from there, you can then move the case along and progress. So you eventually do your discectomy, and then this is your view. And in this view, you can see that the disc has been decompressed, and of course, these are different cases. But the whole goal is to show you guys the beauty of endoscopic spine surgery, the visualization that you can get. So here you can see that the top of the pedicle of L5 is here on the left of your screen. If you follow that pedicle up, you'll see the SAP that's been trimmed and removed so that we can actually see medially. This is a traversing nerve that's completely decompressed, and there's no more disc fragment in front of it there. So again, how do you avoid the pitfalls that come with endoscopic spine surgery? How do you prevent yourself from flailing or having terrible outcomes? And I think the first and most important thing is your case selection. If you're hoping to achieve, great outcomes, it's important to really understand the patient's chief complaint, understand the actual pathology and where it's coming from, and then be confident that your indicated surgical plan is going to provide you the best value of decompression for that patient. So in some cases, you may have someone with what appears to be an L4 radiculopathy. There's some lateral recess stenosis at L3, L4, but there's also foraminal stenosis at L4, L5. Well, I'd send that patient for a block. I would confirm that it's truly the foraminal stenosis and not the lateral recess stenosis. So it's important to understand to that level of degree of patient, selection. The other thing is, you want to make sure that you understand your goals of surgery, if it's to really just remove disc fragment, or is it to actually do a foraminotomy and increase the space in the foramen as well. Being efficient is actually how you get quicker with these cases. And what I mean by being efficient is looking at each individual step, completing it to its completion, just like any other surgery, and then making sure that you progress the procedure in a fashion where you're not going backwards to go and do something over again. That's how you'll actually increase your surgical length of time. And then know your limitations. If this is your first case, don't try an extra foraminal disc. Don't do a far lateral disc for your first case. I can't tell you how many times I'm asked if this is a great indication for your first procedure. So definitely would say be honest with yourself as you do this, because with time and with practice, you'll get better, and you can then tackle these more difficult cases. Some other pitfalls that will, kind of cause you to be in trouble is if you don't have great targeting. If your targeting is off, if your C-arm is off, you're going to find that you're struggling to get your scope to where you want it to be. And that can then decrease your confidence in the procedure and make things, also decreases the morale in the OR, where people are just kind of questioning whether or not you're doing what you said you're doing. So start with basics. AP and lateral, get great targeting techniques, practice it in these cadaver labs, and then allow yourself, the opportunity to really slowly understand not just the anatomy, but how you want to get around that anatomy and how you want to target it. I think there's a big discussion of whether or not to use a Jamshidi or 18 gauge needle. For me, I tend to use the 18 gauge needle when it's for a soft disc herniation, or I have a very large foramen that doesn't need to actually have the SAP removed. If I'm planning on doing a trans-SAP approach, I'll use the Jamshidi, dock it into the SAP, and then use that the reamer system to actually remove the tip of the SAP. And that's a very effective tool where if you have time in the lab, I think it's very important to practice that, because there's some nuances to that technique that makes it a little bit easier to actually remove the bone in a very safe manner. And then, of course, I can't harp on this enough. The SAP, not only is it a formidable opponent, a lot of times it's the actual cause of pain for these patients. So I do remember earlier on in my fellowship doing a case with Christoph. There's one patient that we put a video together for. His SAP, we did our dissection. You can see the SAP is literally just jabbing into the nerve. And so we removed that, and that guy did well. And I think for a lot of people, when you don't understand your anatomy or pathology, the goal is usually just to remove disc. Sometimes the disc isn't the problem, so be cognizant of that as well. And then I won't talk about the far lateral disc anymore. We've talked about that enough. I think once you know that you have seen the exiting and traversing nerves and they're free floating, there's no more compression of it, then you know you've done your job, and you can remove the instrument and actually close the case. Some references. And then, of course, if you want any more content, feel free to check us out on YouTube, Twitter, and LinkedIn. Thank you.
We have to move quickly, pretty fast. Now, one thing is again, maybe we can do that afterwards, but I found it intriguing, to see the postoperative course of these patients, and especially how the recovery is timed so differently. The cases you showed, who is recovering immediately, who is not. I mean, yesterday we showed the ESRG data of, 96% predictive value of the first 2 postoperative days of how they're going to do, but there's certainly certain patients that improve later on. Any comments on that?
Yeah, what I'm noticing is for a lot of it has to deal with the patient themselves. Some of them have unrealistic expectations. Their pain is not just mediated from their radicular pain, but it's also from the depression and trauma in their life that's going on that kind of exacerbates their pain. So I actually do a lot of talking to these patients and counseling them. I put together these videos so they can go and watch the surgery that they're going to have before, and then I really want them to kind of understand that the pain is, or the treatment is, surgery is just one part of the treatment. The long-term treatment plan is lifestyle changes for a lot of these patients. They need to strengthen their core. They need to actually, start stretching and trying to increase their mobility. A lot of these patients have kind of settled into a sedentary lifestyle, which propagates more pain. As far as the patients that I think do really well, those usually are the patients who have a soft disc herniation. They've tried, physical therapy, pain management. They've gone through the whole gamut, maybe saw some small improvement. And then we've also done, even after they've done their non-surgical therapy, I actually still send them for a targeted nerve root block. And if that confirms that that's the pathology or the area of the nerve that's being compressed causing the radiculopathy, we proceed with the targeted discectomy. So for transforaminal, it's important to understand that that's for unilateral pathology. It's going to be very hard to try and treat bilateral pathology, but unilateral symptoms coming from a specific nerve root, you really need to investigate that pain, because once you identify where the pain generator is, you can truly treat just that problem, and the patients have better outcomes.
Hey, I'm sorry for keeping going here right now. I've
one question.
Sure.
Yeah. I'm just curious, and maybe yourself can also answer this. On one of your patients who's doing great at 3 months or 2 months, but like that first 2 weeks, pain level is still really high.
Yeah.
And so, with the app and the Spine Healthy, are they like pinging you every day?
No.
Like, or is it just you can see that?
I see that, and every once in a while I'll reach out to them, say, hey, just checking out how things are going. It looks like, and if I could go back, I'd show you her step data. She doesn't really walk as much. A lot of it's pain related, but it's also just the quality, her lifestyle. And so I do encourage these patients. We'll tell them, hey, you should do some more activity. The pain will get better with time, and just constant encouragement. But they hardly ever text me.
Just that little post-op dysesthesia.
Yeah, precisely.
Do you ever, like, if you're following that and then on the app, you just like bring them in for an epidural just to help speed up that recovery if it's like they're still hurting it like 2 weeks or so?
No, a lot of the patients, if they're really in pain, they'll reach out to me and then they'll ask me, what else can I do? And then we'll target them, either send them for, Lyrica or gabapentin. But for the most part, sending them for more intervention, I haven't had to do just yet. But we'll see how things go at the 6-month, 1-year mark and see how they're doing.
Hey, just one quick question for you, John, and the audience too. Because we have had discussions in our research group. Is so if you have a 4 or 5 lateral recess stenosis, probably pinching the L5 nerve root, who would do the diagnostic block in the L5S1 foramen, or who would do it in the 4-5 foramen? So who would? Does everybody get the question? So you have 4 or 5 lateral recess stenosis. It pinches the L5 nerve root. Are you going to tell your pain doctor to inject into the L5-1 foramen or 4-5? So who would inject into the 4-5 foramen? 4-5, anybody? Anybody else? 4-5, 4-5, 5-5? Over there. Okay, 4-5, so roughly 20%. And who would do 5-1? So we have to study that.
Because most of the pain guys put it on the shoulder of the root.
They go up by the pedicle.
Right.
Yeah, we don't go by the disc.
We do it by the disc.
So there's a difference. It's like my pain doc's gonna go right by the pedicle. And so it's, it depends. Like you're different to it. So Ray's gonna go by the disc. Yeah. So there's a reason why we have different answers.
Yeah, but the question is what nerve root do you want to numb up, right? Because my pain guy goes to the L5 pedicle and numbs up the L5 pedicle. Now the argument could be made that numbing up a nerve distal to the compression doesn't do anything, right? Now when we looked at, actually John looked at, here's the expert, John. We have the data sitting around, but the predictive value was pretty high, right?
Really high, yeah. So we're still waiting for that to actually get published, but the whole goal of this kind of conversation is once you've actually hit the nerve as it exits, the patients who do better or who have pain relief, chances are if you identify the pathology and it's in the level above and you just decompress that lateral recess, that's good enough. And I think what we're trying to figure out is whether when you have both, when you have a disc fragment at the level where they're going to be like a foraminal disc versus lateral recess in the level above, I think that's going to be the next thing we need to look at. But what I'm seeing in my practice, if I do the L5S1, for example, in your example, if I do L5S1 first, and they don't have any relief of their pain, then I'll send them back for 4 or 5. And if that makes them feel better, I'm a little bit more confident that 4 or 5 is going to be the issue.
But if 4 or 5 releases it, then again, this is a very nerdy discussion, but this is what this meeting is here for, right? We're not going to discuss the basics here right now. So if 4-5, so 5-1, let's say you have a patient with lateral recess stenosis, 5-1 doesn't help the patient. You do 4-5, it helps. Then your hands are bound, and you almost have to do a transforaminal approach, right? You have to assume that some of the pain comes from the L4 nerve root too.
Yeah.
Would that be correct?
I think what Mark was alluding to is, it just really depends on the definition of less so the title and, well, less so the title and more of the definition, like where is that needle going and what nerve are you targeting? I think if you ask that question differently, what nerve do we all want to target, we'd all raise our hands to the same nerve root. But you know, a 4-5 transforaminal injection could mean something completely different based on who does it. So putting a little asterisk there and making sure we define what that means, I think it's important before we even study it.
I also think it's important what your goal is. If it's purely diagnostic, I think your approach, Christoph, is good. You know, you want to just get the L5 nerve root at the 5-1 foramen. But if you're also doing a therapeutic and diagnostic injection, like say preoperatively, and you're putting some steroid, if you do it like Ray does it, you know, at the disc level at 4-5, you have the steroid where the inflammation is and stuff. So I think you get better pain relief with that, plus some diagnostic, you know, but it's also obviously blocking both the 5 and the 4 nerve root.
So what I see in like a case of severe L4-5 stenosis with L5 nerve root compression, the issue with doing the sort of pain approach to the 5-1 foramen, which is the 6 o'clock point on the pedicle lateral to the exiting root, that's where they put the injection. Most of that stuff flows extraforaminal. The pain guys will say, well, the medicine, it's 2 cc's, it flows up above to the next root, goes all the way up to the shoulder, and that's true in a normal spine. But in a stenotic spine, that's like a cork in a bottle. It doesn't flow there. And when you do epidurograms, and you do epidurograms consistently on thousands of patients, you'll see that there's a flow defect. I dictate that in my injection notes. There's a flow void. That's where the nerve root's compressed. And sometimes the epidurogram gives you more information than the MRI does, because you're looking at the MRI and you're like, that doesn't look too bad, and you do the epidurogram, and there is no dye flow in that spot, and it outlines everything else. So if you have a L4-5 lateral recess stenosis and you do a 5-1 transforaminal injection with the pain approach at 6 o'clock point on the pedicle, and you get no relief, okay, there's 3 possibilities. 1, the stenosis is so severe that the injection is not enough and you should operate on them. That patient's going to do well. 2, you're completely wrong with your diagnosis and that patient's going to do terrible. 3, they have pathology in the nerve that's so painful that no matter what you do, they're not going to get better. 2 of those 3 I don't want to operate on. So there's only the one of those 3 is your best surgical candidate. And we're always saying, we got to do the indications are the most important thing. Well, if indications are the most important thing, how we do the injection and how we interpret that injection is the most important thing, because that's what predicts your indication and your surgical outcome the best, in my experience. And again, anecdotal, N of 1, but that's my take on it.
Just to make a real quick point on the neurobiology, right? So we're talking about anesthetic injections, right? If you're injecting at the root sleeve, you will not necessarily get the same numbing effect as if you're injecting on the DRG, right? So if you were bathing the DRG, you will effectively calm down the pain transmission proximally. Okay, just so that everybody's know that, like when you numb the pseudoponal neurons in the DRG, you relieve the pain. So that's the reason why the pain guys tend to do it right at the pedicle.